Welcome to The Explainer. Today we're diving into something absolutely crucial. We're talking about respiratory failure. Look, it's one of the most high-stakes, high-stress scenarios you can ever face in a clinical setting. When a patient literally can't breathe, panic can spread like wildfire. Not just for them, but even for newer practitioners trying to treat them. But what if we could instantly cut through all that chaos? What if you could take the whole shebang of the human respiratory system and organize it into a brilliantly simple, perfectly structured framework? One that tells you exactly what's going wrong and exactly what you need to do to fix it. Well, that's exactly what we're going to do today. We're breaking down the dual approach to respiratory failure management and turning a terrifying emergency into a clear, actionable mental model.
Okay, let's dive into this with a pretty wild question. Can simple math actually explain respiratory failure? I know. It sounds totally counterintuitive. The human body is immensely complex, right? It's filled with all these intricate feedback loops and biological systems. But here's the thing. In a life-or-death emergency, you don't have time to thumb through a textbook. You need clear, decisive logic. You literally need a formula. And as you'll see, it turns out the vast, complicated landscape of respiratory failure can actually be distilled into some of the most basic equations we learned as kids. We're going to look at how basic numbers and basic equations can solve complex clinical emergencies, letting you instantly pinpoint the problem and deploy the right life-saving fix without missing a single beat.
To get started, we have to establish the core dichotomy of how lungs actually fail. Respiratory failure fundamentally splits into two very distinct clinical paths. On the left, we've got type 1. This is characterized purely by hypoxemia, meaning just low oxygen. Now, on the right, we have type 2. This one is compounded. It's low oxygen combined with hypercapnia, which is retained CO2. Basically, every single time you encounter a respiratory crisis, your brain needs to instantly route that patient down one of these two pathways based on the specific disturbances in their blood. Distinguishing between these two paths is absolutely the foundational step. Why? Because confusing them can lead you straight down the wrong treatment protocol, and we definitely want to avoid that.
All right, let's start with type 1. I really want you to burn this giant number 1 into your mind. Everything about this specific type of failure revolves around a single, isolated problem that requires a single, focused response. By stripping away all the dense medical jargon and just anchoring ourselves to this massive number 1 on screen, this brilliantly illustrates the concept of singularity in this condition and completely clears up your cognitive load.
So in type 1 respiratory failure, you've got exactly one primary disturbance: low oxygen. The body just isn't getting enough oxygen into the bloodstream. And because there is only one single disturbance, medical logic dictates we need one immediate, direct correction: give oxygen. Honestly, it really is that straightforward at its core. You identify the single deficit, and you supply the exact element that's missing. The mathematical beauty here is absolutely undeniable. One disturbance literally equals one correction.
Now, as great as that simple math is, applying oxygen is just the immediate fix. It's not the final cure. You have your one primary correction, so the crucial point is that resolving the underlying cause is always the final step of the correction. Consider what's going on behind the scenes. Maybe it's an airspace disease like pneumonia or ARDS, a perfusion block like a pulmonary embolism, or fluid overload from heart failure and pulmonary edema. Septic shock and early asthma fit right in here too. In all of these cases, the primary isolated physiological failure is oxygen exchange at the alveolar level. You give the oxygen to stabilize them, right? And then you attack whichever root cause put them in danger in the first place.
But what happens when the lungs fail in a different, more compounded way? Well, we shift gears dramatically to the number 2. This number signals a huge escalation in our medical math framework. If the number 1 was all about a singular deficit, the number 2 is a giant red flag telling us that the patient's respiratory system is battling on multiple fronts. The stakes are raised, the physiological mechanics are totally altered, and you know what? Our approach has to scale up right alongside it.
In type 2 respiratory failure, we essentially double the trouble. We now have two disturbances happening at the exact same time. Hypoxia, just like we saw in type 1, but now it's paired with hypercapnia. The body is failing to bring oxygen in, and it's completely failing to push the carbon dioxide out. Because we have two distinct disturbances, we absolutely must deploy two distinct corrections. First, we provide oxygen. Second, we bring in a non-invasive CPAP machine or a BiPAP to treat that high CO2. It provides the mechanical support the lungs desperately need to literally blow off that trapped gas. It's simple math again. Two problems, two targeted solutions.
And just like before, we have to treat the root cause of this dual disturbance. The culprits here usually involve compromised mechanics or a central drive issue. We're talking mechanical restrictions from things like COPD, obesity apnea, or neuromuscular weakness. Or it could be a depressed central nervous system from drugs, think opioids or diazepam. The patient simply cannot move enough air to clear the CO2. Now, what's really interesting about this slide is how asthma shifts categories depending on its severity. Wait a minute, didn't we just discuss asthma as a type 1 issue?
Well, this evolution of an asthma attack shows exactly why categorizing the failure correctly is literally a matter of life and breath. Check this out. During an early attack, the patient is usually hyperventilating, breathing incredibly fast. Because of this, they're actually blowing off plenty of CO2, but their constricted airways prevent enough oxygen from getting in. That's a single disturbance, low O2, making it type 1. But if that attack progresses to severe asthma, the patient's breathing muscles become completely exhausted. I mean, they are tired out. They can't hyperventilate anymore. Their breathing slows down, and suddenly they stop clearing the CO2. Now it's building up in their blood right alongside the low oxygen. They have just crossed the threshold into type 2 respiratory failure. The math changed, which means your life-saving corrections must change instantly.
Let's move to and see how this builds into a memorable, punchy takeaway. Our source material elegantly synthesizes this entire concept into a single rule. So type 1 respiratory failure, 1 correction. Type 2 respiratory failure, 2 correction. I mean, it is just a beautifully concise summary of a really complex medical philosophy. By framing it exactly this way, you completely remove the hesitation that can paralyze decision-making during a medical code. You just count the disturbances and you immediately know the exact number of corrections required.
So here it is all laid out. Think of this as your ultimate mental anchor. 1 disturbance of low oxygen demands 1 correction of providing oxygen. The equation is 1 equals 1. 2 disturbances of low oxygen and high CO2 demand dual corrections of oxygen and ventilation to blow off the gas. The equation is 2 equals 2. And of course, the golden rule in both scenarios, you always treat the underlying root causes. This summary grid takes complex, intimidating pathology and turns it into instant recall for those high-stress, terrifying environments.
Because when a patient's breathing is failing, every single second counts. The margin for error is virtually zero. You don't have the luxury of overthinking things. You need clarity, you need structure, and most importantly, you need to act. So I'm going to leave you with this provocative thought to chew on. Now that you understand the fundamental logic behind the pathology, if every second counts, will you remember 1 equals 1 and 2 equals 2? Because armed with this ridiculously simple, structured knowledge, you now have a wildly powerful tool to instantly understand, categorize, and mentally manage a respiratory crisis. Thanks so much for joining me for this explainer, and definitely keep this medical math ready in your back pocket for when